Okay, so I think we are. So welcome everybody. Thank you very much for joining this webinar today between the World Psychiatric Association and CHiMES. We are recording the meeting today, and I think the chat will be transcribed as well. We have two speakers today, Dr. Tennyson Lee and Professor Bhui. If you do have any questions, please do try to use the question and answer function rather than the chat, and I will monitor that. We're hoping to have about 30 to 40 minutes of presentation and to leave plenty of time for discussion afterwards. So I'm just going to hand over now to Professor Bhui.
Thank you very much, Roisin. Tennyson and I are delighted to be here to present this seminar. I'm just going to make some opening comments and orientate you to the collaboration that we've been building over several years. So this is a collaboration between the World Psychiatric Association collaborating centres, and they are located in Egypt, Hong Kong, India, Italy, Kenya, Qatar, South Africa, and UK, and the latest one in Denmark. As well as the CHiMES Collaborative at the University of Oxford. This is a creative collaborative of advanced interdisciplinary research, policy and practice. And really, we're trying to develop new methodologies and critiques from cultural psychiatry and health inequalities research to test and evolve ecosocial, biopsychosocial and syndemic frameworks. In that context, Tennyson and I have been working together as co-directors of CUSP, a Centre for Understanding Personality. And CUSP has lots of functions. It's a collaborative between the University of Oxford, QMUL, East London NHS Foundation and Oxford Health and a number of other organisations. And the main purpose of CUSP is to improve our understanding of personality function, in particular when people with personality difficulties come into contact with services, but also in society. Our specific objectives, which you can find in our annual report, is to contribute to evidence-based research in the assessment and management of personality disorder, to establish a setting for clinicians to develop skills and conduct research, to provide training. We do a lot of training, provide evidence-based training in personality disorder and psychotherapy, and also support the development of better services and better systems of care and support for people with personality difficulties and disorder. So we very much welcome people who want to become part of the group, and indeed we're going to be establishing executive committees and other committees. So if you're interested at all after the seminar, please do get in touch with us, and we're very happy to share contacts and build our plan for the next year with you. So personality disorder, personality difficulties, personality functioning, this is a really challenging topic for many clinicians and those working in health and social care more generally. It's a topic that doesn't get enough attention. We know personality disorder is stigmatized. We know people with personality disorder have complex lives, multiple sources of adversity, and are challenged in finding ways of accessing services and finding the care that they receive supportive. They're often disadvantaged already due to multiple adversities and socioeconomic circumstances, and then they find the support they get isn't entirely aligned with what they find helpful. And we'll unpack some of that, and part of the purpose of today is to support people in training and thinking about personality function, irrespective of the stage of experience that you're at, the stage of your career, because this is a continuous problem that we all must manage on a daily basis when we work with people with personality difficulties. Trainees in particular, and GPs and those who don't work in psychiatry, and sometimes those who work in psychiatry all the time, find it extremely challenging to work with people with personality difficulties, not least because you have to be emotionally attentive. It can be emotionally exhausting. And one area of work which has contributed substantially to work of personality, developing therapeutics in personality difficulties, is psychoanalytic thinking. Now, there's a long tradition of psychoanalytic thinking that is maybe dated, and what we're wanting to do today is present to you the advances in psychoanalytic thinking, and also connecting psychoanalytic thinking to all the learning from the social sciences, humanities, from psychology, from cultural studies, and indeed neuroscience. That's the most exciting bit of the presentation that you'll hear today, that Tennyson's been working on for a long time. And I've been delighted to work with Tennyson. He's an analyst and a clinician in the NHS. He's been really supportive of trainees, working with them sometimes over 10 years, whilst they're trying to write a single paper and understand what the challenges are. Because sometimes the difficulties in therapeutics also enters into the writing of the paper and writing up about the paper and learning itself. So we're really quite privileged to have Tennyson and all his expertise over decades, leading the Dean Cross service in East London, but also being a leading light in training and research globally, and you'll hear more about that in a moment. So I'll hand over to Tennyson for his presentation, which I'm really looking forward to. Thank you.
Thanks very much, Cam. So let me just see if I can share my slides. Cam, I can see you. Can you just give a thumbs up if you can? That's great. So thanks very much to Cam and his team for organizing this talk. That's the title. The aim of the talk is to give an overview of Transference Focused Psychotherapy, and then to say, well, why TFP, and to give an argument for why TFP actually is very useful for us at this point in time. Now you can see that there's too much for us to do. So essentially what I'm going to do is sort of walk or sort of jog you through some of the main aspects. I recommend just sort of sit and listen and take in which aspects you think are more useful for you. Just about all of this, Cam and I have written up in various forms, and we will circulate a couple of papers after this meeting. So, but I imagine most of us are clinicians in this meeting. So let's think of probably the kind of encounter that you had yesterday and the previous week. So let's say this is a 34-year-old Black British female who's unemployed, and she presents with a history of self-harm, chaotic behavior, and she says to you, I want to feel better. She talks about her partner, who she loves actually, and her children, who clearly she holds very dearly. She has a typical history of someone that presents with a diagnosed borderline personality disorder, lots of visits to primary care, lots of presentations to emergency department, lots of admissions, and a confusing array of diagnoses. You can see, so she had about 4 different diagnoses of different kinds of personality disorder, PTSD, depressive disorder, bipolar disorder, and a whole cocktail of medications. Now, I'm going to play a video of the assessment, and in this assessment, we join 20 minutes into the meeting. And just to note that at the time when she's talking about a teenage daughter who she's very concerned about. So I'm sure we're very, very familiar with this kind of occurrence. And I suppose the question is, what do we do? And the proposal in this meeting is that TFP does have some contribution to make to these very difficult situations. So what is TFP? You can see there's a photo of Otto Kernberg, who originated TFP, and one can think of it as an evidence-based approach to treating patients with personality disorder for all different kinds of psychiatric settings. It's useful to think of it as a structural understanding of personality and also a structured approach. And I'll unpack what I mean by structural and structured, because I'm using them with different meanings. In terms of a structured approach, TFP is particularly interested in the structures of personality, and these are the particular structures that it looks at: one's sense of identity, the kinds of defense operations that the patient's making, contact with reality testing, you can see how if one starts thinking in this way, one starts getting a way to view what's happening with the patient that we've just seen. Now, the usefulness of having a structural approach is it allows one to start thinking about levels of personality organization. So as you can see, as you're going down the map over here, the level of personality organization becomes worse. Also, what's so useful is that Kernberg has conceptualized a number of the more specific personality disorders, for example, borderline, narcissism, histrionic, antisocial, under the term borderline personality organization, therefore capturing that in fact it's a dimensional concept, personality disorder. They're not separate entities. So it's a very useful way to start thinking about personality. Now, once we have structures of personality, we can start, it allows us to start thinking of the level of severity. So for example, in the patient we've just seen, we would assess as having a mid-level borderline personality organization. And then one can start thinking of the structures I've just mentioned in terms of identity, what kind of defense mechanisms. Over here, we would think that this patient has a poorly consolidated sense of her identity. Her defenses are very splitting based. She can often lose contact with a sense of social reality. Can you see how it starts immediately allowing one to start processing the information as you're seeing the patient? Similarly, by having the levels of personality organization, it's, for example, in our case, it allows us to think, well, this is a mid-level of borderline personality organization. In fact, the prognosis is good, that TFP has an evidence base for the effective treatment of borderline personality disorder. Again, it helps us to think, for this patient, we might want to very much focus on the nonverbal communication, the way the patient behaves and acts, and also on our countertransference. So again, knowing the level of personality organization is very helpful clinically for us. Now I'm going to speak about, we're still on the structures of personality, and TFP is a contemporary object relations approach. Now, for those colleagues in the group that haven't spent a lot of time on this theory, it's a very odd terminology, but if I just say father, you immediately, I hope, would have a sense of a benign older man who's kindly and loving, has taken a helpful guiding role in your development. And therefore, once you have a sense of father, you have a sense of yourself, you as a child or as an adult, as the child of your father. And you can already see that what links the two is an affect, and again, hopefully, an affect of love. Now, if we think of the patient that we just saw in the video, we could surmise that her father was someone that was neglectful or uncaring, and therefore none of the affects that I've just mentioned, the more benign, loving ones, would be strong in terms of how she viewed herself in relation to, in this case, the father. Now, where TFP starts taking off is that because it's an analytic approach, it starts thinking of the dynamics of our psychology. And therefore, it starts thinking that none of us would like to be in the victim role. And what we then do is we flip it over. So we become a bit persecuting, as happened in the video you just saw, where the patient starts threatening to self-harm, and in that way gains a sense of control. She becomes rather persecuting of the clinician. Now, if you look at this slide, what it captures is the real dynamism of thinking analytically, where I've just described this dyad, this object relations dyad. The dyad is just a self and other representation bound by an affect. That's over here. But what I've brought into this slide as well is that there's another dyad present, which is a far more libidinal, loving one, which might be present but less easy to see because the more difficult way of the patient relating is more on the surface. Now you can see that this is where the model or this way of thinking really becomes very alive, because you can start thinking in the encounter with the patient, why is it so difficult? Is it because there's been a reversal of roles? And then again, suddenly the patient switches and they're very affectionate towards you. What might that be about? And then you start thinking of the other dyad which might be present as well. Now I'm coming on to, I finished on the structures of personality. I'm coming on to the structured approach. And I think that TFP, what it contributes to our thinking as clinicians is it's very structured, it's very ordered in its way of thinking, and it divides our way of working with patients into overall strategies, tactics, and techniques. And I'll just speak very briefly to each of these. In terms of the strategy, this is the strategy. The overall aim in Transference Focused Psychotherapy is to help the patient to get a greater sense of their inner world. In other words, the way that they tend to view others or themselves through their internal object representation. So that's the overall strategy in our work with the patient. The tactics are to set the field in which one does the psychological work with the patient. So it's the setting of the treatment contract and maintaining the treatment frame. And then Kernberg did a very provocative thing, Arthur Kernberg, who invented TFP. He said, if you give me all the analytic techniques, I will propose that there are 4. And so he says that if you think of all the different techniques in psychoanalysis, that if you consider the transference, the counter-transference, how one goes about making interpretations and maintaining technical neutrality, there you've captured the main techniques of that one needs to use when one is working dynamically with the patient. I've added in the 5th one, using the 3 channels of communication, because it's so important and helpful for us to keep those in mind, particularly with our borderline patients. And this is just going a bit more into the 3 channels of communication, that if we think of what happened in the video we saw, there was quite a lot of non-verbal communication happening. The patient was fidgeting, she was getting agitated, and one can really think that there's a lot of information potentially conveyed in how the clinician would have been feeling at the time. In other words, the clinician's countertransference. Here you can see this clinician isn't doing particularly well because he's looking down. He's not noticed that this patient is starting to lose grip in the meeting, and he's not even noticed now that there's this is getting quite a severe look from the patient. So I've given a brief overview on TFP, and what I'm going to do now is just speak to some of the new developments which give support to the benefit or the use of TFP. So the first one's around, there's been really important developments in affective neuroscience. And given that our patients come to us mainly because they have problems with the feelings they experience, it's very helpful for us to really focus on the developments in affective neuroscience. Just, if we think that Freud describes 2 main drives, what's so important now is to realize actually the science is showing that there are actually more than 2. And one of the more authoritative models by Jaak Panksepp describes 7 emotional drives. I'll just take one real a couple of leaps forward in terms of saying what is the clinical relevance of this. And some of the clinical relevances of this is that Soames, who has developed neuropsychoanalysis, in other words, the use of affective neuroscience in terms of how he thinks analytically, has described a lot about how one can use this thinking. And there's been a back and forth between him and Kernberg. And I bring Kernberg in because clearly Kernberg as the originator of TFP. So the back and forth communication between them is a very interesting one. And it's partly some of the differences are premised on the thought of, are there 2 main drives or are there in fact 7? But just to go back to the 7 drives, these are the drives which Panksepp says if the mammalian brain is hardwired into having these emotional drives, each of which need to be met. For us to survive, we need to meet them. So, for example, seeking, the curiosity, going out into the world, go out into the world and seek, the basic emotional need of lust, of caring for our offspring. Now, the point about this is that one can start seeing the link to TFP, because which of these drives, these emotional needs, do not need an object? One lusts after an object. One needs to care for an object. One panics or one feels concerned about the loved object leaving us. So all of these are inherently object related, and by definition, we're talking about primary emotional needs. We're talking about affect. So one can see how the developments in affective neuroscience map on very closely onto TFP. Again, just to note that these networks that Panksepp describes they're not sort of used as metaphors. He's mapped out the brain areas involved and the neuromodulators involved as well. This is just a slide to, in a way, underline the primacy of the emotional processes, and that one can start thinking that as one moves up the brain, there's then a greater role for cognition. But one can also use this diagram to think, where are the different psychotherapy modalities mainly operating? For example, one could think CBT is mainly working at the level of cognition, whereas analytic work, and for example, TFP is mainly working at the level of primary process thinking. So again, it's very helpful to just get some sense of what's the main level of intervention of the different evidence-based treatments. Coming on to evidence-based treatments, just to note that TFP is an evidence-based approach, and there have been a number of RCTs which have shown its effectiveness. Again, this is just to show that when there's been imaging of the brain pre and post TFP, it's what one would expect, that there's been post-treatment, post-effective treatment, up-regulation of the prefrontal cortex and down-regulation of the limbic system. So again, it makes sense in terms of how psychotherapy is working. And again, I think this is such an important major paper where the main developers of the different models are saying that there's an evidence base for DBT, MBT, TFP, schema-focused, and there is no approach which is superior to any other. So I think, again, if we think of this, I think it gets away from the, at times, unnecessary jockeying of positions of the different treatments. They all work, the evidence-based ones, but they work at different levels of the brain. What I'm going on to now is the present diagnostic systems. So in terms of ICD-11, the steps that one follows are, first of all, to make the decision, is a personality disorder present, yes or no? And the way that one decides is one looks at self and interpersonal functioning. The second question is, what's the level of severity? Is it mild, moderate, severe? So that's ICD-11 for personality disorder. If we look at the alternative model for DSM-5 for personality disorder, you can see that there's an absolute echo, a mirroring, because it's self and interpersonal, and it's the level of impairment. You can see that ICD-11 alternative model for DSM-5, they absolutely map onto one another. But then if we think about that, it maps onto TFP, because is a personality disorder present, yes or no? One looks at self and interpersonal. That's exactly what we're thinking about in TFP in terms of self and other representation. And then question number 2, what's the level of severity? It's exactly what TFP does in terms of looking at the level of personality organization. So again, the proposal would be TFP maps on very well to present thinking in ICD-11 and the alternative model in DSM-5. So let's come back to the clinical application. So again, this was the patient that we just saw. Now, if one starts having an object relations approach to understanding the interaction, if one starts thinking of what's the way to understand what's happening at a structural level of personality, in other words, one starts thinking of how's the patient, experiencing themselves, how are they experiencing me? I'm now feeling very anxious. Oh, it's a reversal of the diet. All of this is very, very helpful in terms of how one can start thinking about the encounter. And then if one starts thinking of how might I use issues around the transference, countertransference, being not getting too drawn into any of the opposing parts of the diet, how do I work systematic in terms of interpretation, how do I use the 3 channels of communication, all of those are very, very helpful in managing when the clinician really has very little idea of what can they do which is useful. So to the management encounter, a structural approach helps one to get ready before you go, before you make the structured intervention. And I don't have time to go into all of this now, but this is the example of what one could do in terms of trying to manage the encounter, the very, very fraught encounter that's happening with the patient. You can see that there's attempts at clarification, thinking about the role reversals. Again, very systematic approach to making an interpretation. So the reason why I've gone through this quite quickly, all of what I've said is in this paper, which we will be sending the URLs. It's freely available. And what we're suggesting TFP is useful in is it helps the clinician to just tolerate being confused, to start thinking, how do you use the feelings that you're having, to start thinking of the dyads, and to start trying to de-escalate the situation. Now, I'm moving towards the end of the slide. So just to say that TFP has been applied at a number of different levels for different age groups, for adolescents. It's been used for neurotic presentations. There's been a major book brought out on treatment for narcissism. There's there's some initial work on group TFP. There's work forming on couple therapy. And I want to mainly think about the work that's just come out, the book that's just come out by Richard Hirsch and Chiara Panfilis on applied TFP. Now, this is the book. This just came out last year, but as you can see, there have been other work done on applied TFP. Now, one of the main interests in applied TFP is and again, it might be of relevance to the present group in this seminar. I imagine a lot of you are working in general adult psychiatric settings. So again, just to come back to the work that Cam and I have been doing, we've been doing training in 5 countries on applied TFP to psychiatrists. So our initial training was in the United Kingdom. We've done work with colleagues in South Africa, in Italy, and India. This over here, you can see it's a very low resource intervention because Cam and I did some online meetings. Most of our work is online, and here we're having a workshop where one of the participants is role-playing a patient, and we go through what's a systematic way that the TFP clinician can manage the very, very difficult encounter. And we presently are doing work with colleagues in Malaysia. Now, the point about all of these is that we've used what are now validated instruments, the attitudes to personality disorder questionnaire and clinical competence with personality disorder, and we found that on a short teaching intervention, some of them as short as, the shortest has been about 3 hours, we've shown a significant change in both attitudes and clinical competence. So the proposal is that an evidence-based teaching on the application of its approach to generalists working with personality disorder has been shown to be effective. It's also been useful in terms of training trainees in how to do psychodynamic psychotherapy. Now, this is an important development that if we think that in terms of use of medication, that more than 90% of our patients with borderline personality disorder are on medication, yet there's no evidence-based justification for its use. So why do we do it? So this has been addressed by Richard Hirsch for years. And just to note work that's been done within the UK, that there's a group headed up by Rula Constantinidou, Dimitris Trotanis, and David Rogalski, where we've done work on thinking about the object relations dynamic and what's happening, which leads clinicians to prescribe when there's no evidence base for prescribing. We've also got a chapter coming out in the Moores guidelines, again, just trying to address this very, very difficult aspect of the pressures placed on psychiatrists in terms of prescribing. So that's the end, and this is an invitation. As Cam says, we'd be delighted to have colleagues who might be attending the seminar who are interested in doing related work. We're particularly interested in psychodynamics of prescribing, development of PD services in the public sector. We've done a lot of work around in terms of training at primary care level, if the colleagues that are interested in that. And then based on Cam's very strong work in cultural aspects, we've also done some work around the cultural aspects of personality disorder. Again, if there are colleagues that are interested in training other than who we've trained so far, in other words, there's been thoughts about training receptionists or teachers or police or ambulance workers, religious leaders. Again, if their colleagues are interested in doing any of that work, Cam and I would be delighted to think about how we can take it forward. And this is the other invitation. It's ISTFP, International Society for TFP. I find it's professionally a very rewarding organization. It's a very generous one, and one where clinicians are very, very interested in how one thinks clinically and theoretically. So it's a warm invitation to consider joining our society. And there's a very happy Otto Kernberg at one of our meetings. Thanks, everyone. So that's the...
Thank you so much, Tennyson. That was fantastic. I just wanted to see if Cam, as a discussant, if you had any reflections for about 5 minutes. I can see one question in the Q&A so far, but if others have reflections, please do add them, and we'll save about 15 minutes for discussion at the end.
So thank you, Tennyson. I mean, the opening video kind of captured the sort of daily challenges that people find, although they might happen at reception, they might happen in the street, they might happen in the ward, they might happen in all sorts of places. And I think people are unnecessarily hopeless about the interactions because they're not quite aware what's going on, and themselves become emotionally disturbed, distressed, dysregulated. And so the methodology of psychiatry work is really powerful because it relies on the clinician having a self-awareness and some skills in emotional management and communication, and being aware of, as you say, how these things flip. You can be in a meeting and suddenly, from being persecuted, you feel like you're the persecutor, because and then the countertransference is quite important, and that's something that I don't think any other therapeutic approach offers at the moment. And I know we've got lots of digital health. I'm yet to see how AI might manage countertransference, but that'll be interesting conversation to have with people. So that's what we're trying to help support people with, only the people living with personality difficulties, but also the clinicians and sometimes family members as well, and others who are interested and want to be helpful and supportive. It's quite challenging. And as Tennyson says, people are aware and they want to have help, and they want others not to be, their children not to have to put up with the difficulties that they're having, and they're aware of that. So that's a really powerful, positive aspect of this. And as Tennyson said, the evidence is that there's a lot to be hopeful about in terms of treatment outcomes compared to many other health problems, physical health problems as well as mental health problems. But people don't know about it and don't necessarily go and get the skills and training. Then the second bit, which is very exciting, is, as I mentioned earlier, the beginning to modernize Freudian concepts and analytic concepts from all the great analytic writers and leaders. They were operating experientially. We value experience-based co-design these days and experiential perspectives and peer research. And from their experiences, it's almost sort of psychoanalytic surgery, really. They were identifying subtle changes in feeling. And what we're doing now is modernizing that and thinking harder about what are the neurological, neuroscientific correlates, not just for the sake of it, but to understand how our interventions might be helpful and how to improve them, but also to link up the different evidence bases that exist across neuroscience, psychological sciences, social sciences, and so forth, and rather than all of these operating silos, ultimately for the benefit of the public, but also we can't afford, science is moving very fast and we need to sort of keep up and be athletic in our approach. So they were my two reflections, and as always, very much enjoyed it. And the joy of seeing people in other parts of the world really hungry for this knowledge and experience, and how much just a little bit of sharing of this knowledge will help. One of my charities I set up years ago, that was our motto, share knowledge, change lives. And this is a classic example of what's happening. So thanks for that. And well, back to you, Roisin. Yeah.
Thanks, Cam. It was really fantastic. I just wondered as well if you could speak a bit more on the cultural aspect. And there was a few different contexts there that you'd done some training in of this approach. I think it would be quite valuable. And then I'll go to some of the questions in the chat.
Yeah, I mean, I'll say briefly what the evidence is. So first of all, personality difficulties, disorder, distress, functioning is less often identified or diagnosed in Black and minority ethnic people in high-income countries. And there are all sorts of possible explanations for that. One of them simply might be we don't understand enough about personality and character and dare not make such judgments in other people. Or it could be that we misclassify. We know equally that they have higher rates of psychosis and other conditions. I don't think that's happening. I think we genuinely have a different type of presentation of emotional regulation and the way distress presents, partly linked to this interpersonal and sociological expression of distress. That distress might be experienced between people rather than as an embodied self, which we're used to in the West and in individualistic societies. So we know that's the case, and comparing US and UK literature, there are differences in the way diagnosis is made of personality difficulties. We do know if structured instruments are used, you get less of those differences. So there is something about clinical variation, and obviously clinical variation brings in clinical practice and the way we operate, and the scripts we use and the stereotypes we deploy in everyday practice. And regrettably, the more experienced you are, the more scripts you use, and with confidence. And I guess we just need to reflect on that and think about that. Tennyson, you might want to comment a bit about the experience of working with colleagues in India and other parts of the world, the trainees that you work with, and what the hell the other issue is cultural competence, and tackling inequalities is a high income country issue. It's where that we talk about it a lot. In the low middle income countries, they've just got stuff they need to deal with, and it's slightly different salience. But I don't know if you have anything to add, Tennyson, if we had to adapt any of the trainings or do anything different with it.
Just two things. The one is that one of the thoughts that we've had is that how people view problems, or not even view things as problems, may be different in different communities. And so we're very interested in whether some religious leaders in our patch might be serving some function which in a more traditional health system might be seen as what the GP would be thinking of. So that's the one aspect. The other aspect is to say, when I'm supervising, say, my colleagues in China, say in Chengdu, then I think, actually, is this a patient that I've just seen in East London? Because there's something finally about how we as human beings are, where a someone with a borderline personality disorder is someone with a borderline personality disorder, whatever area they're living in. So there's something about just acknowledging the basic humanity of all of us, where we are structured the same. It may manifest differently, but in the detail of a psychotherapy setting, one can see we are all the same.
Thank you, that's great. I'm just going to combine two of the questions in the chat, because I think they're both coming from similar angles. One of them asks, do you feel hopeful or hopeless about the place of psychoanalytic thinking in UK mental health services in the current environment? And are there specific goals for TFP that you have in mind? And the other asks is whether you would suggest TFP alongside other PD therapies, such as a patient having both TFP and CBT at the same time.
I think that's for you to start with, Tennyson. I'll chip in.
So I've just had news that in my trust there are 2 medical psychotherapy posts which are being chopped. So one could say, one could feel pessimistic about that. I've just met with an early intervention service, and we've had a very good discussion on how to understand a psychotic patient, a floridly psychotic patient, in an analytic way. So I think my answer is that there'll be an ongoing realization of the need for analytic thinking. So I feel optimistic about that. The other question I think is a very important question, and that in a way is why that World Psychiatry paper is such an important one, which is saying the evidence-based treatments should be given equivalence of respect. However, if one thinks of how the brain works, one should then think that the different treatments work at different levels of the brain and therefore address different problems. So I think that if someone is going for both of them, I think one should think of resources, why both at the same time, but there might be some issues which can be addressed through CBT, which don't need the intensity of an analytic treatment. But again, it goes back to Cam's emphasis that we should be working on the evidence we have. And if one has an understanding of memory and how memory works, then I think we should help our managers to realize that there are some problems that cannot be solved cognitively. They need to be addressed at the level of affect, because memory is, it's not as though all aspects of memory are symbolized and therefore can be addressed at a cognitive level. It needs to be worked at an unconscious level, and therefore it needs the role. It comes back to, am I optimistic about analytic work? And I'm saying, yes, I am, because human problems will not be solved unless one tries to think of the unconscious as well.
Yeah. So I am hopeful also. The reason is that services change, policies change, and of course in our local context and where we're working in high or low income countries, there'll be different receptivities to psychoanalytic thinking, sometimes perhaps prejudicial or stereotypical, or just they're imagined to be very intensive and costly because they can take place several times a week at the higher end of intensity. I think all of that is open to change, but what won't change, as Tennyson is saying, is the fundamental methodology of working clinically and the need for it. If anything, there's such a massive need out there, and it's painful to see that people living in precarity, unable to access a psychoanalytic form of deeper therapy that might be more helpful to them than in a way them being forced into a care pathway that clearly isn't going to meet their need at a deeper level. And indeed, they know it when they get referred to CBT, or they kind of are wondering what's happening because they kind of are aware it's not right in some shape or form. The other element of that's important is irrespective of, and Tennyson's second point about psychosis argues for this as well, is that irrespective of what the services are delivering to patients or the public even, the skill set of the clinician is really important, irrespective of whether it's called a psychotherapy service or whether it's called a psychosis service or whether it's a depression service or whether it's a primary care. Having these skills is really important to help support your work with any patient with physical health problems, with pain, it's also really important, and we perhaps don't talk about this enough, in terms of managing your own emotions in working in challenging environments. It's also, I found it enormously helpful in working with colleagues and in teams and in dynamic situations, and actually trying to make sense of uncertainty and complexity in services. So when services do cut your post, you can get demoralized and go into a corner and say that's the end of the world. Or you can say, right, how do we address this in this situation? How do we continue to provide something? Working in partnership with charities and public bodies is important, but also continuing to provide, if you like, health literacy for the public around these issues is really important. And we have to do it as clinicians, as we have ethical values that we must live up to. We must continue to do the best we can, irrespective of which service we're in and what they say we should or shouldn't do. You know, what's commissioned, we have a responsibility to try and continue to provide the best we can on the basis of evidence.
Thanks, Cam. And it's been asked in the chat as well. I wonder if you confirm that I think a lot of your work that you've presented was in adult psychiatric services. And it's been asked about whether this approach would also be applicable to children and young people with behavioural concerns, and what adaptations you think may be required.
So I think it's a great question. So there has been a lot of thinking on transference focused psychotherapy for adolescents. So that colleague, to know that there has been there's a text out on that, and there's some research out on that as well. I mean, in a way, if we're thinking TFP is a form of analytic thinking, and we would then think, well, analytic thinking could be relevant, as Cam says, for not just for psychotherapy, but for different clinical issues, but also for all age groups. Why should it not be relevant? We're just thinking about one psychology, really. So I think I'm glad that that colleague has asked that question, so that we can think, yes, that we would think of it as being utterly relevant for, different age groups, really.
And it's also been asked about the application of this in forensic settings.
Yeah.
And they've noticed you particularly mentioned about TFP with narcissism, and therefore wondering about the application to domestic violence perpetrators.
Yeah, no, that's a really interesting question. So there is within the ISTFP, there is a forensic psychiatry group, which I don't know much of, so I don't know much of their work. But I think that colleague asks a very interesting question, because Kernberg is reputed as being one of the analysts that has done the most of the thinking around aggression. So I think it's very relevant for that reason. The other one is that TFP, as opposed to mentalization-based therapy, has less of a prognostic hope for patients that are very, very antisocial. So I think it's a fascinating question that's being asked. And maybe it's pointing to, I suppose, the different emphases of the different approaches, so that we can respect MBT and TFP, but just realize that they at times have different models of how things work, really. But, for example, to acknowledge our MBT colleagues, they've done fantastic work, and there's been a recent Lancet journal which has shown the effectiveness of MBT for antisocial patients. So that's very, very good finding.
Pam, did you have any reflections you wanted to add on those two questions?
These are really good questions, because the majority of people don't get enough in whichever setting, and then there are special settings like forensic services and child and adolescent care and forensic child and adolescent care. But we're also talking not just about personality function, but there may be coexistence of multiple problems like depression and personality difficulties, which is again very challenging to treat, and TFP can be helpful there. And it may be, I think the question was, do you use more than one therapy at a time? I think there has to be some rationale for it, but it may be that, and that comes down to patient preference a little bit in what people feel they want, their expectations, explanatory models, what they feel they can cope with, and actually what they can cope with, because none of this work is easy for the patient or for the clinician, really. So I think it's important to continue to, and Tennyson's mentioned the Lancet paper, it's important to continue to do more work in this space, and to improve our understanding of what works for where and for whom, not least because personality difficulties are sometimes just ignored. People aren't meant to be admitted. Shouldn't be detained. They shouldn't be treated with antidepressants, for example, or antipsychotics. So they tend to be sort of drifting around, and the level of care or support isn't consistent. And there are no sort of minimum standards of what each area, for example, should be offering in order to support the expected level of people with personality difficulties in that patch, which is what we try and do with depression and psychosis, for example, not always brilliantly. So there's a whole area of work that needs to be done more. That also means sharing our understanding with policymakers and commissioners and politicians as well, because it's really important they understand the quality of it. And that's probably something we've not been good at, is absolutely properly communicating with other people what we do. We tend to sort of cherish our precious training and knowledge, and we need to share it more widely and make it accessible.
Thank you both ever so much. We've got about 3 minutes left. So I just wanted to let people know as well that if you want to be notified about future CHiMES and WPA seminars, please do email us on the email address that Eve has put in the chat, if you're not already on our mailing list. We've also had a comment in the Q&A from somebody who's actually an A-level student interested in pursuing the field of psychiatry. I just thought a nice way to close out, as we've got two very eminent and successful psychiatrists here, if you wanted to give some very brief, what would your kind of one key suggestion or recommendation for her be?
Do it, is what I would say. And get as much exposure and experience as you can. And if someone says don't do it, ignore them. We need the best and the brightest. It's a really challenging field to be in, and there's a massive shortage. So please do it. And if you need support, guidance, or help, I'm sure Tennyson and I would be very happy to talk to you.
Tennyson?
Yeah, I agree. Do it, and don't, if I can hope that you don't lose your psychological interest. And, if you think of Eric Kandel saying that psychoanalysis is a way to think about our psychiatric work, which makes it satisfying because it actually makes us think about the mind and the psychological aspects of the brain. So I hope, colleague, that you do enter into what I think is a wonderful discipline.
Thank you very much. Well, thank you ever so much, everyone, for attending. It's been a fantastic and very interesting discussion. We have recorded this webinar. It is our first time using Teams for this, and I think that has been fairly successful. And we'll then kind of work out how to share that recording with you afterwards. Our next CHiMES and WPA webinar will be on the 10th of April. I'm presenting myself alongside a colleague from Uganda, and we'll both be presenting on our use of photo voice with people who have experienced psychosis in those two quite different contexts. And I'm sure Eve will send out the link to register for that seminar shortly. So thank you very much, everybody, for attending, and I hope you manage to enjoy the sunshine wherever you are and enjoy the rest of the month. Take care. Thank you very much and goodbye.
Bye.